Hello, I'm Pearl Avery. I'm an inflammatory bowel disease nurse consultant at Dorset County Hospital in the UK. We've been using the IBDoc calprotectin tests with our patients since 2016, and this year we have done a retrospective audit looking at the use to check that we're still getting value from the test and that patients are still getting value from the test. So we have done a retrospective audit and we presented this abstract at ECCO 2020. So this audit ran between July 2017 and October 2019. There were 134 patients enrolled on the IBDoc system completely. 23 patients failed to carry out tests for various reasons. Sometimes it was about patients just forgetting about the tests. They'd put them in the fridge and then never do them and they'd run out of date. Other patients found that they didn't actually get on with the smartphone technology as well as they thought they might, so they failed the tests for that reason. And other people were actually enrolled on the system but never took a test away. So actually those 23 patients, out of those 23 patients, there's only 10 patients that actually failed to carry out a kit. So over the period of all of that time, we thought that that was a really reasonable dropout rate and that there wasn't much waste at all. What we then did was we looked to compare the calprotectin result with a most recent endoscopic evaluation. So it might have been a colonoscopy or a flexible sigmoidoscopy. So we looked 6 months either side of the calprotectin result just to try and find some colonoscopies, because what we actually found was that they weren't being done as frequently as we thought they might have been done. So out of the eventually audited results, only 31 patients actually had an endoscopic evaluation. 80 patients who had a calprotectin done during that time went off and were well and had minimal interventions or had disease modifying treatment adjusted based on the result that we got from the IBDoc. So actually you could almost say that having that instantaneous calprotectin result stopped us needing to go for a flexible sigmoidoscopy to evaluate disease. Of the 111 patients who had a active result from the calprotectin, we had Crohn's disease patients were 55 and UC patients were 56, and IBDU patients, so that's inflammatory bowel disease of unknown origin, there were 2 patients. We actually had 2 non-IBD patients within that group as well, who actually turned out to have non-IBD related inflammatory things going on, which was quite interesting. So 80 patients that did not undergo any endoscopic evaluation. And of the 31 who did, correlation between the calprotectin results and the colonoscopy results was good at 84%. And 100% correlation was found in the most severe cases, both from a colonoscopy point of view and from a calprotectin point of view. There were 5 anomalous results, which we found out patients either had, one patient had Clostridium difficile, another patient was severely constipated. In fact, there was 3 patients were severely constipated, and 1 patient was proximally constipated associated with their disease. But the colonoscopy was really mild. It was a very interesting set of results that provided us a different aspect of thinking about managing patients. So now we're managing constipation in our patients maybe a little bit more effectively, because we know that it can cause some discomfort and damage to them. So of the patients that were well, we looked at whether we had modified any treatment based on the disease result. So with the normal results, 41 of those well patients had a normal result and we didn't adjust any treatment at all. 2 patients we decided to monitor a little more closely. They were on patients that were on biologics, and we wanted another normal result before we made any difference or any changes to their treatment. one patient that we adjusted treatment on in that group actually stopped treatment. So again, that's a win if you're looking at the value of the treatment. So the moderate results in that group as well, there were 8 in total, and 1 patient was well, 7 patients we decided to monitor, so we would have done more frequent calprotectin tests. There's no hard and fast rule about how we do these. Some patients we're doing them 6 weekly, other patients we're doing them 2 weekly. It depends on the severity of the disease and also what support the patient needs. So if the patient feels they're getting benefit from this, and they do, they'll report to us that they want to do those tests more frequently because they want to see their disease progression. They want to know if they're getting better. They want to know if the treatments are working. So that's been really interesting and helpful to the patients. When we moved down to the unwell patients in that group, there were 28 patients that reported a high result. In 6 cases, we monitored those patients, and in 22 cases, we actually adjusted their disease. So out of that whole 80 patients, there were 23 patients who had adjustments made to their treatment at that time. 2 patients went on for surgery in an emergent situation, but those patients that went on for emergency surgery went in well prepared, knowing that actually their result was high and they needed to go forward for that. So really, in conclusion, this poster and this retrospective audit proved the continuing value of the IBDoc test to the trust and to our patients as well. And it also shows that we may be doing less colonoscopies. Obviously, we'd need to look at what's going on in the standard group of patients where calprotectins are being sent away. And it may be that we need to look at that data to see if there is that trend with using the IBDoc. But I was surprised at how few colonoscopies and flexible sigmoidoscopies there were. It does reflect the fact that there's difficulty in getting into slots in endoscopy to do quick evaluations for patients in the UK. So there's definitely a capacity issue. So the other thing is there's the supported self-management side of the test, which offers patients some autonomy. It gives them a chance to take some control back of their disease, which can become all-consuming. If you're unsure about what's going on inside your body and you're worried because you're bleeding or you're having your bowels open 20 times a day, having a simple result to tell you whether this is all stress-related because you've got a pile or something else going on, rather than it being active inflammatory bowel disease, can help a patient just to manage that those symptoms that they're having. And equally, having that instantaneous result, if it's high, they know they're going to get treatment in a faster fashion than while we wait for tests to come back from the lab 2 to 3 weeks down the line. I think this test offers further opportunities in conjunction with other digital tools, so patient-reported outcome measures, and that's our next aim, is to get this all integrated so that we're using this in a joined-up way for patients to have access to a web portal that does everything for them that they would possibly want. That allows us to manage patients more remotely, hopefully, maybe relieve some of the pressure in outpatients in terms of patient flow and patient movement, and hopefully we can sort out waiting lists and things like that.